Understand the part 2. So in this part 2 we'll start with follicular or proliferative phase of menstrual cycle. So first what you need to understand is what is follicular phase or proliferative phase. The phase which is between the day 1 and day 14. You know that the menstrual cycle is of total 28 days. On the day 14 there is ovulation. It will start from day 1, that is the last missed period. So if you see according to this, the period between day 1 and day 14, that period is called follicular or proliferative phase, or in other ways you can say the phase which is before ovulation. Okay, so in this phase actually what happened on the day 1, you know that the FSH will go and act on granulosa cell. It will release the estrogen, and it is because of release of estrogen, it is having negative effect on FSH, and there is proliferation of endometrium because of estrogen, and there is positive feedback on LH because of estrogen. So that is leading to LH surge, and because of that LH surge there is ovulation on day 14. Okay, and you know that only dominant follicle is selected because of this negative feedback of FSH, that estrogen will select only single follicle, that it will lead to atresia of remaining follicles. So the dominant follicle will increase in size, and the names of the dominant follicle, as you can see here, the small one indicates the preantral, and the some medium one indicates the antral follicle, and the mature dominant one is a Graafian follicle, and the Graafian follicle is like about 18 to 20 millimeters in size. Okay, so note that the ovarian cycle is initiated by follicle stimulating hormone, and the size of follicle just before ovulation is 18 to 20 millimeters. And for LSH to occur, estrogen should be 200 picograms for 48 hours. Okay, so LS surge is just 32 to 36 hours before ovulation, or even for the FSH it is same. FSH and LS surge are 32 to 36 hours before ovulation, or the other best one will be 24 to 36 hours before ovulation. Okay, first best will be 32 to 36 hours before ovulation, second best will be 24 to 36 hours before ovulation. So coming to LH peak, LH peak is 10 to 12 hours before ovulation. So you can see here, this is LH surge. In this LH surge also, this is called as LH peak. So LH peak from the time of ovulation is 10 to 12 hours difference. Okay, and the time interval between the estrogen peak, you can see both the estrogen and LH. When the estrogen will go into peak, then only LH will go into peak, right? Because estrogen is only leading to LH peak. So the time interval between the estrogen peak to the LH peak is like about 14 to 24 hours. Okay, so LH surge is initiated by estrogen. LH surge is maintained by both estrogen and progesterone. This is important because we already know that from the granulosa cell there is only no production. There is not only production of estrogen, but the progesterone is also produced from the granulosa cells by acting of luteinizing hormone. So LH surge is maintained by both estrogen and progesterone. So before ovulation there is LH and FSH surge, and ovulation is mainly due to LH surge only. Okay, so meiosis 1 is resumed due to LH surge, that is 32 to 36 hours before ovulation, and that is leading to formation of secondary oocyte and one polar body. So till ovulation this phase is called follicular phase because it is mainly because of follicle formation FSH, and it is also called as proliferative phase because the endometrium is under proliferative condition because of estrogen. Okay, so now coming to the day 14. On the day 14 exactly ovulation takes place, that is the primary oocyte is converted into secondary oocyte. If you see the diagram of primary oocyte, it would be something like this. Like the primary oocyte is covered by cumulus oophorus, which are of granulosa cells which are surrounding the primary oocyte, and you will be having an antral follicle, antral cavity, and the lining here is all over granulosa cells. So this is called as antral follicle, that is this one. This is preantral. We have seen already preantral, this one. Okay, that is just with the granulosa and theca cells. Okay, and the antral one, in the antrum one you will have antrum cavity, that's it. And next will be Graafian follicle. Okay, so normally the antral cavity fluid, the fluid which is present here is estrogen, growth factor, and also luteinizing hormone. And luteinizing hormone appears in the antral cavity fluid only towards mid cycle. So in the mid cycle you will see the luteinizing hormone which is appearing in the antral cavity fluid. Okay, now coming to anovulation. Sometimes what happens is if luteinizing hormone appears in antral cavity fluid early in the cycle. So what we are seeing, luteinizing hormone in the antral cavity is towards only mid cycle. But sometimes luteinizing hormone will come so fast that it appears early. That will lead to atresia of follicle, decreased mitotic activity of granulosa cell, and that will lead to aovulation. So the aovulation process and ovulation is seen in PCOD patients, that their luteinizing hormone is appearing from the early cycle because of more estrogen. The problem in PCOD is there is low progesterone, so there is more estrogen. So because of the more estrogen, the luteinizing hormone is also more. So from the early stage only, luteinizing hormone is more in antral fluid. So because of that, there is decreased mitotic activity of granulosa cells and leading to and ovulation. Now let us discuss about the secretory phase, also called as luteal phase, that is from day 14, between day 14 to day 28. Why this is called as secretory phase? Because here the endometrium is in secretory phase. Okay, so this phase is why it is called luteal phase, because it is mainly maintained by LH hormone. You know, the first half of the cycle is mainly maintained by FSH hormone, right? And the second half is mainly maintained by luteinizing hormone. And the first of the cycle, the main hormone is estrogen. In the second half of the cycle, the main hormone is progesterone. How? Let us see. So now the primary oocyte is finally secondary oocyte, right? And the follicle is now the corpus luteum. So luteinizing hormone maintains the corpus luteum in a non-pregnant female. Okay. Then in pregnant female, who maintains corpus luteum? That is her HCG. Okay. So coming to corpus luteum. Corpus luteum start growing under the effect of luteinizing hormone. Okay. So on the day 22 of cycle, so somewhere over here, day 22. Okay. So on the day 22 of cycle, or you can say 8 days after ovulation, it attains maximum size in cavity. So corpus luteum will attain a maximum size in cavity on the day 22. So the hormones which are produced by corpus luteum are progesterone, estrogen, and inhibin A. So if you remember, inhibin B is formed by FSH, right? Because of acting on granulosa cell, it is producing estrogen and inhibin B. But inhibin A is produced by corpus luteum. Okay, so corpus luteum mainly produces progesterone. So progesterone will have a negative feedback on luteinizing hormone. Always remember, a simple way to remember this is which will form this kind of hormones, that on that only they will show the negative effects, right? So here, as the luteinizing hormone is producing progesterone, progesterone will have negative feedback on luteinizing hormone. Okay, and it is having secretory action, that is it supports the uterine endometrium. Coming to estrogen, estrogen and inhibin A both will decrease FSH. Okay, because they are having a negative effect on FSH. Already we know about this. Now coming to note, at low concentration of progesterone, there is high amount of luteinizing hormone, of course, because low negative effect, so high LH and high FSH. But in the high concentration of progesterone, there will be low LH and low FSH. Now let us start a discussion on corpus luteum degeneration. So what happens when the corpus luteum will degenerate? Okay, so whenever there is low LH, because whenever there is high LH means corpus luteum is formed. So low LH means there is corpus luteum degeneration. When there is low LH means it is nothing but there is low progesterone, low estrogen, and also low inhibin A. Right, so whenever there is low progesterone, the support to the endometrium is lost and endometrium will shed off, that is menstruation. So now that uterine endometrium have superficial and deep layer, the superficial layer will shed at the time of menstruation, whereas the deep layer, that is the zona basalis, will be always getting ready for the next menstrual cycle. Okay, so next coming to whenever the progesterone is low, it is a smooth muscle relaxant, so whenever it is low, it will lead to vasoconstriction, and because of that there is release of PGF2 alpha, and because of this PGF2 alpha there is increase in myometrial contractions, and that because of that there is pain during menstruation. So whenever female gets pain during menstruation, that is called dysmenorrhea, and that is mainly because of increased myometrial contractions, that is because of PGF2 alpha when progesterone is low. Okay, so coming to decrease in estrogen, because of decrease in estrogen and because of decrease in inhibin A, there is more FSH because it has negative effect on FSH. So now FSH will increase as a negative feedback is gone. So now it will act on granulosa cell and will lead to increase in estrogen and proliferate the deep layer of endometrium. So what does it mean? Whenever the corpus luteum is degenerating, it is again starting for the another cycle, right? Because progesterone is decreasing, so this endometrium will shed off, and even PGF2 alpha will release. That is why there is pain during bleeding. And estrogen is decreasing, and inhibin hay, because they are decreasing, they are giving positive feedback to FSH, that is FSH is increasing, and because of this again estrogen is increasing, so again starting readying for the next cycle. So always remember the D player is responsible for regeneration of entire endometrium in the next cycle. Okay. So coming to the maximum size, actually the maximum size of a follicle will act on progesterone, estrogen and inhibin hay. Mainly progesterone, because it will lead to secretory action, and also it will decrease the luteinizing hormone. So progesterone, you can say it is a main hormone in the menstrual cycle, because progesterone will uh, lead to secretory action, and also it will decrease the luteinizing hormone. So that is why whenever in a female there is sudden drop in progesterone, it will lead to menstrual bleeding. So second half of menstrual cycle is called luteal or secretory phase. So one-liners in menstrual cycle, this is very important. The main hormone in the first half, estrogen. In the second half, progesterone. First half is follicular phase, mainly dependent on cycle length. Second half is luteal phase, which is fixed duration. And day of ovulation, you can count from 14 days backwards from the next day of menstruation, or you can say total length of the cycle minus 14. For example, if a female have 30 days cycle, you do 13 minus 14, then what is the answer? On that day she will have ovulation. Okay. And next, coming to corpus luteum. The corpus luteum maintains corpus luteum in non-pregnant female, that is luteinizing hormone. Maintains corpus luteum in pregnant female is HCG. And the lifespan of corpus luteum in non-pregnant female is like about 10 to 12 days, whereas the lifespan of corpus luteum in pregnant female is 10 to 12 weeks. Okay, and protects corpus luteum from undergoing luteolysis is HCG. Now coming to levels of hormones. All hormones peak at the time of ovulation, that is luteinizing hormone FSH. Estrogen peaks just before 24 to 36 hours, that is important. Estrogen 24 to 36 hours, whereas you know that LH and FSH between 32 to 36 hours. Estrogen 24 to 36 hours. Progesterone peak on day 22 of cycle, because we discussed before that on day 22 of cycle there is corpus luteum. Because of corpus luteum only there is increase of progesterone on day 22. So finally coming to day 22. On day 22, progesterone will peak. Size of corpus luteum is maximum. All tests for ovulation are done on day 22. At high concentration of progesterone, there is negative feedback on both LH and FSH. So level of LH, FSH are minimum in secretory phase or day 22 of cycle, or you can say 1 week before menstruation. Next, coming to another one, that is Mittelschmerz syndrome. So in this there is a mid-cycle abdominal pain, or you can say pain in abdomen at the time of ovulation. So coming to characteristics of menstrual cycle, initially high levels of progesterone support endometrium. Eventually progesterone level decrease and support of endometrium is lost, leading to menstruation. The most important hormone needed for menstruation is progesterone. Progesterone cannot act unless endometrium is primed with estrogen. In case of postponing or preponing menses 2 to 3 days before expected date of menstruation, start progesterone 5 mg Primolut and TDS. High progesterone levels. Once top level of progesterone will go down, menstruation start after 2 to 3 days. So female complaints of delayed menstruation 10 days. Sexually active female, urine pregnancy test positive, then pregnancy. Most common cause of secondary amenorrhea, increased progesterone levels, support decidua, and pregnant endometrium. If no menstruation after delivery, placenta is removed, decreased progesterone levels, shedding of decidua, lochia. Next, coming to negative female, UPT negative, reduced progesterone levels, shedding of endometrium, menstruation duct, Meprate 10 mg, BD or TDS, 5 to 7 days, increased progesterone levels. Once stop progesterone level fall down, loss of endometrial support, menstruation starts. So female with complaints of anovulation. In that female, there will be no corpus luteum or reduced or absent progesterone, so amenorrhea, or hormone present, estrogen is present, so it proliferates endometrium, shedding of weak endometrium, estrogen breakthrough bleeding. So estrogen breakthrough bleeding can occur only at any day, that is anovulatory cycle, irregular, painless, heavy bleeding. Coming to normal menstrual cycle, sudden decrease in progesterone levels, release of metalloproteinase enzyme, ischemic necrosis of endometrium, endometrial shedding, vasoconstriction, PGF2 alpha release, increased myometrial contraction, dysmenorrhea, pain during menstruation, indication of ovulation indirect.